this point, I need to stop and thank you, offer acknowledgement to our main sponsors for this evening's event through a non-restricted charitable donation. We have funds from Celgene and Sanofi-Genzyme that helped to bring the program tonight. Thank you for that.
First, let's give a round of applause to Laura for taking care of this business tonight. For all of you that do not know me, yes, I'm Stuart Schlossman. I too have multiple sclerosis. I've been doing this a long time, and we wanted to bring this special program to you. And this, everybody, I want you to know, this is my A-team, all right? And I want you all to thank them for getting over here tonight in spite of all the traffic problems, in spite of the weather that was to be, but they were here because we want to make sure that we're going to provide this great program to you. So this roundtable discussion is with Doctors Hunter, Boster, and Kantor. That was a great way to combine some of the names there, okay? And again, my name is Stuart Schlossman. I'm asking the doctors' responses to be complete yet brief as possible so we can hear from all three with their different viewpoints and so we can get through all the questions before then asking and turning over to you all, what questions you may have. So we're going to go through different questions for about 30 minutes, and I'm going to ask each one of them to answer, and I'm going to try to keep them on cue, and then we're just going to afterwards, we're going to have the field mics out here, and we're going to have people going around the room. And at that time, whatever questions you have about MS, please try to keep it as general as possible because they're not your doctors. And even if one is your doctor, they don't want to answer as doctor-patient right now, all right? So you got to just ask questions in general. Even if, again, you feel it's about you, ask it like it's not about you, okay? So my first question is this. Multiple sclerosis today versus years ago. Can you please tell us about the progress? Maybe you can each share what it is that you find most remarkable in the progress, in the treatment options, the diagnostic tools, and I'll keep going afterwards. So,
I'll start off. Howdy, by the way. I guess here I can say howdy, y'all. I think the most amazing thing in the modern era with regards to MS is the waiting room. So the waiting rooms in MS centers a decade or two ago were comprised of spaces for wheelchairs and walkers. And we don't see that today. With the early application of highly effective therapy, with a commitment towards fitness and diet, we have literally changed the natural history of this disease for the better.
Well, when I saw my first patient with MS, which was about 33 years ago, I was training and I asked the neurologist who was training me, well, what do we do for this? And he says, we don't have anything to do for MS. I don't like to tell them they even have MS, and I don't usually until they're not able to walk very well. And now we have so many treatments, it's hard to even explain it to you. And you guys are a market. Industry is working for you. Research is working for you. The MS Society is working for you. Even the government sometimes turns out to be working for you. It's a wonderful situation.
Well, I guess my answer is hope. And my answer is not necessarily the waiting rooms, but the virtual waiting rooms. Look what we're doing right now. We're sitting here in a great room in the wonderful city of Nashville, Tennessee, and people are on the internet able to watch what's going on. That's dramatically changed. The way information is processed, the way information is shared, has been changed so dramatically in the last 5, 10, 15, 20 years.
Can you tell us specifically what are the best or the newest diagnostic tools that you're coming up with to find that a person has multiple sclerosis?
So MS remains a diagnosis that's clinical. It remains a diagnosis where a person with potential multiple sclerosis still talks to a person who happens to be a neurologist. And by taking a really careful history and doing a really careful examination, that's still the best thing we have. Now, there are other fancy tools. And MRI machines, I think everybody here loves that chugga-chugga sound of an MRI machine, and the claustrophobia are getting better and better. And other tools like lab tests are getting better and better. But I think that's still that fundamental issue of MS, that it's one person with another person in the room together trying to solve and figure out what's going on.
Neurologists are right 100% of the time, as long as you don't ask more than one. Yeah, but whoever sees it, it basically is responsible for it, and the MRI's right 80% of the time, a spinal fluid's right 80% of the time, electrodiagnostic tests are right 80% of the time, neurologists are right 100% of the time. You know, as I'm fond of telling people who've been trying for a while to get a diagnosis, it's all in your head, it's just not your imagination. But, you know, and that kind of morbid humor suits neurologists very well. But when you see the problem, the amazing thing about it is it's really going to come back. Sometimes it's hard to know when it's going to come back, and there are definitely some people who have it milder than others, but it just comes back. And even when people don't know what's going on, it continues.
So I'll highlight two pieces of technology. As my colleagues mentioned, the MRI has revolutionized how we diagnose. Using the MRI, we can diagnose MS after the very first attack. And in fact, we're diagnosing faster and faster, and that means that we can put people on therapy quicker and quicker and have better and better outcomes. Also, there's a lab test which is being studied increasingly called neurofilament light chain. And right now, the best data looks like it's from the spinal fluid, which my patients don't love, but we're hopeful there'll be a blood test. And this might be the first serum biomarker to help guide us in MS. It's not prime time yet, but it's exciting data that's emerging.
Great. Thank you for that answer. Now, let me ask you another thing. Managing what's going on with your patients now versus years ago, how has that gotten better for the patient?
It's a tremendous teamwork and a tremendous effort to make someone the most awesome version of them possible despite having this disease. And when I was training, which was like 2 days ago, you know, it was only about applying the disease-modifying therapy, and that's yesteryear. We take so much more of a comprehensive approach in trying to optimize someone. And what that person needs that particular day at that particular time might be an occupational therapist, or it might be a counselor, or it might be a drug to help with bladder.
I have to say that it's a wonderful thing when a patient comes to me and say, I can't get the people to understand around me I'm sick. And they keep telling me I look good. And I'm like, it's much better to look good than not to look good. But that's probably going back to what Dr. Boster said about what the waiting room looks like. That's what's changed, is we've moved from a treatment paradigm that was involved about rehabilitation and trying to keep people functioning to trying to keep people normal. And if you've ever seen the hierarchy of needs humanity has, it starts with, you know, water, food, shelter. Yeah, it goes on. MS is the same way. You want to walk. You want to be able to take care of your personal needs. You want to be able to do everything, and then you want to be able to live the same kind of life you always live. We're working on that. We're working on making MS better and better. In my shameless research plug. Research is what makes the future better. If you have a chance to be in a research trial, do it.
Well, some things have gotten better, like we've heard, but some things have gotten worse. So we've seen increasing government regulation. We've seen increasing quasi-governmental regulation with organizations that are non-governmental that are making decisions for us. We've seen our healthcare organizations, our health insurances make tougher and tougher decisions. So while some things have gotten better in terms of management, some things have gotten harder. And that's why it behooves all of us to really come together and to advocate on behalf of ourselves, on behalf of the doctors need to help with the people with multiple sclerosis, and we all need to work together to try to make that best possible outcome.
Thank you. So one last thing on this topic, and that is that, and without naming the actual medications, can you tell everybody though, you know, the benefit of, you know, getting diagnosed now with the treatment options that there are versus 30 years ago?
So in 1992, there were 0 FDA-approved medications. Our first medication was FDA-approved in 1993. We now have 12 separate branded products, 1 branded generic and 2 unbranded generics. That's an amazing leap forward. And every year, we're going to see 1 to 2 new medications come out. So really, there's a lot of hope for the future.
There's, I would say we have lots of ways to beat MS, lots of sticks to beat it with. Some are bigger than others, and we're still learning how to do it 30 years into this.
Some of the newer medications have demonstrated outcomes that I didn't think I'd ever get to see. And so 15, 20 years ago, we were hopeful that we could decrease the frequency of an attack, maybe make it happen less often, or decrease the number of spots on MRI. The three of us spend our day trying to have no spots and no attacks. And in fact, with some of our newer medicines applied really early, we're seeing in some groups confirmed improvement of disability. And so it really is an exciting new world.
Thank you for that. So can you tell us now the differences of what the different patients go through? What makes one patient, their MS, a little bit more different than the next patient?
So multiple sclerosis is this interplay between your immune system, which is unique to you. If you have a twin, they have a different immune system because they got a different cold when they were 3 years old. And it's the interface between that immune system and your nervous system. And the nervous system develops uniquely in you because you played baseball and your twin didn't. And so it's that interplay. And that's unique for every human on Earth. And as a result, it's unique for every person struggling with MS. And so if I see 16 patients in a busy clinic day, I'll see 16 different chief complaints. And they all have the same condition. Because it's fair game to attack anything in the central nervous system, brain, spinal cord, optic nerves. And that creates a tremendous amount of variability.
It's really, there's a lot of randomness to it. You will see families where a lot of people have MS. Most is not the case. There'll be all differing problems, all differing severities. Identical twins don't both get MS. If you look at all the MRI scans of people off the street, about 3% of everybody on an MRI scan looks like they have MS, and obviously they don't have it. They haven't had any problems that they notice or that someone can measure. So there's a lot of randomness. Many of the disabilities people have are willy-nilly, and people who have difficult MS end up looking alike because it hits the same long pathways again and again, and their legs and their bladder and their balance end up being affected. So people tend to look very different when their disease is milder or earlier, and they tend to look very similar when they've had more long-standing problems. People who are diagnosed over 40 tend to have disability at onset. People who are younger are usually more lucky, but by the time they get to 40, they usually have disability. So the nervous system does not put up with the process and repair itself as well as people get older. That describes a lot of the differences.
Some of the variability or differences we understand, and some of it we really don't understand. And I think it's important for everyone here in the audience and everyone online to realize half of what we think we know in medicine, we find out that every 10, 20 years is wrong. Not just a little bit wrong, but 180 degrees wrong. And so we understand some of it, but there's still a lot more for us to understand.
Thank you for those answers. Now, can you tell us the different types of MS, starting with the most benign and elevating?
Well, we can think about MS in different ways, and some of it's about lumping versus splitting, and some of it's just about name calling, and it's just putting a label onto something. But one general way of thinking about MS is thinking about it in terms of, is it more about the relapses, about those attacks, those flares or exacerbations, not exasperations, or is it more about the progression? Or is it really a mixture of both? And so we come up with different kinds of names, and we change those names every so often. So we used to talk about 4 subtypes of MS, and now we really talk about 3 subtypes. We talk about relapsing remitting MS, and then some people go on to develop what we call secondary progressive MS. And then some people say, what are you talking about, getting better and getting worse? From the beginning, things have gotten slowly worse. And we call that type of MS primary progressive MS.
Gentlemen? Do you have anything to add?
Well, microscopically in the brain tissue, there's only one kind of MS, and what we see is different courses to it and different speeds to it. We call it, if you still have absolutely hardly anything wrong with you after 30 years, we call it benign MS, and if it's like gangbusters, we call it malignant MS, and there are big lesions, little lesions, slow lesions, fast lesions, lesions that repair well, lesions that don't repair well. How we describe it is a shorthand. It's a lot like saying that's a bad student, that's a good student. You can summarize it, but it's not really a different disease. It's just how that person does.
I think that as we move forward in time and as research helps us understand better the underlying pathophysiology of MS, we'll start to eventually describe it properly with genomics and with immunologic factors. And we're not there yet. And so we still use these outward descriptions, which, as my colleagues have shared, are lacking. That's coming, and I hope that in our careers that we can start to define MS more properly as it relates to what's actually happening in the human.
Thank you for those answers. Now going on to something a little bit different. A person walks into your office and you believe they have MS. How do you speak with that patient, with their caregiver? What do you urge them to have their caregivers present? And how do you break the news to them?
We can't answer that question in 3 minutes, Stuart.
You got 2.5.
So that's an hour and a half long conversation, and it's a repeated conversation over several separate visits. There's a tremendous amount that you have to cover, and I guess what I would say is you first have to take the pulse of the room. Sometimes when you tell someone they have MS, they're done listening. They can't hear anymore. It's overwhelming. And the very best thing you can do is schedule an appointment the following week. Adopting a concept of having a chronic condition that you'll die with, not from, isn't an easy pill to swallow, and everyone gets there at different times. It's been my experience in my practice that it takes my patients about 1 to 2 years to start to feel comfortable in their skin with their diagnosis.
I would say there's a third of people who are pretty early in the disease process when we see them, and it's clear they have an MS type disease, at least at the beginning, and there's 2/3 that have had it for a while. For the third that haven't really had a lot of experience with it, it can be a real shock. For the other 2/3, it's usually a relief to understand what it is, and it's not a mental illness or their hypochondriasis or whatever it's been called, by other people. So, and what people need is very individual, and we try to listen and give them the information they need to make decisions and explain how we treat it to prevent it, how we treat it for the symptoms, and how they need to manage it.
Well, it's not just about the person who's going to be diagnosed with MS. It may be about the people around them and how knowledgeable they are. Stuart's heard me say this, but a person in Deltona, Florida, she told her best friend, I have MS, and her best friend said, my house is a mess too. As you can imagine, we still have a lot of education, and with World MS Day happening tomorrow, we still have a lot of stigma to get away from this diagnosis. And Stuart, I would correct you. I wouldn't say a caregiver, I would say a care partner.
Amen.
And in multiple sclerosis, we most often talk about a person and their partner. And their partner, it's important that there's really a give and take. And it's important that it's still a partnership. And that the person with MS doesn't feel like they're always receiving, that they're also giving towards that relationship.
I agree. Okay, so thank you again. Now, another thing, logistics of MS or the prevalence of MS. Can you tell us how that sits into our population?
So in terms of the prevalence just means how many people in a population actually have a certain diagnosis. And we used to talk about this number, 450,000. And I think everybody in this room probably thinks that that was too low a number. And then at the end of last year, there started being a new number that was close to 1 million people with multiple sclerosis in this country. The truth is we don't exactly know exactly how many people have, and I don't think it's that important, the exact number. Because frankly, I don't see the government increasing funding on anything that has to do with research. And so what's important is that MS is not uncommon. It's not very, very rare. It's not common, but it's not necessarily something rare.
Thank you.
MS isn't a genetic disease. It's a random disease that's genetically predisposed. So the risk is inherited, but not the disease. It depends when you get misperceptions depending on what kind of denominator you use. If you want to look at the risk of the higher risk groups, which are white women, by middle age, over 1% of white women meet MS, and everybody else is less. The men are a third that, the non-Caucasians are about a third that, and so then you get a realistic picture of how common it is, and it's very similar to other similar immune diseases.
What they said.
And in addition to what they said, why is it that men are only a third of the population with MS?
We don't know, and I don't mean like we don't know, like it's unclear. There's a fascinating statistic that over the last 2 decades, the incidence of multiple sclerosis has climbed in almost all countries, only in women. And it's not clear as to why that is. And the obvious answers, like estrogen, don't seem to pan out when we study it yet.
I will tell you the answer.
Please do.
It is they have 2 X chromosomes.
So going a little bit further with this though, I forgot my question. I must have MS. Going a little bit further, do men get MS stronger than women? Do women get it stronger than men? Is it affect Caucasian over African American? Which one sits in which population?
So we can take general broad strokes on this idea of who gets MS worse. It doesn't mean for an individual person, if you fit into one of these categories, that's necessarily where you're going to be or you're not going to be. But although we think of MS as being more common in women, if you're a man with MS, oftentimes the MS can be worse. Although we think of MS in general as being more common in women of Caucasian descent, if you're an African American man, oftentimes the MS might be more aggressive. Now, that doesn't mean for everybody who's African American it's going to be more aggressive. It doesn't mean for everybody who's a white woman they're going to be less aggressive. But those are some general kinds of categories.
And that can actually help us when we meet someone as we try our very best to prognosticate or to plan for the next 30, 40 years. And so that might predispose us to be a little bit more, a little bit less concerned. But the reality is, this is an N of 1, and you're meeting with an individual human being, and you're trying to do the best job you can with them. So that data is helpful in a big picture. But in the clinic, it's just one person that you're working with or one family.
There are a lot of factors involved in these issues, and there are a lot of myths, and the disease appears to be changing. Why is it changing? Well, everything's changing about humanity. We're healthier. We're living decades longer than we were 50 years ago, and the immune system's different too. The first book I ever read about MS said people didn't get MS over the age of 30. That's obviously not the case. Most people get it over the age of 30. So things have changed. And the immune system's still somewhat of a black box, and there are hundreds of genes that are involved in risk, and there's surely hundreds that are involved in how bad it is. And race is a very artificial definition, and most people who claim a different heritage here, who are non-Caucasian, have substantial European genetic lineage now, and those are where the risk genes come from. They probably have to do with fighting infections.
Location for MS. I mean, did we touch on anything to do with it being worse in the north or worse in the central or in the along the equator? And we hear a lot about MS and the amount of people with MS in Puerto Rico. I mean, what has changed over the years for where defining MS actually comes from?
So most people who take care of people with MS think of MS as having this kind of differences how far you are from the equator. Where you're further north or further south, further away from the equator, MS is more common. Not everyone believes that, and actually the late Bill Shermata, an MS specialist who passed away recently in the past year and a half, he didn't actually believe that. And some of the reasons he didn't believe that is he thought that your actual genetics of where you come from are more important than where you actually were born or where you lived before puberty. Most of the people, though, who do research in the field think that the closer you live to the equator, the lower the risk is. But then you bring up a big topic. What about Puerto Rico? Puerto Rico is not that far from the equator, yet if you look at how many people have MS in Puerto Rico, it's a lot of people. Recent estimates are 70 per 100,000 people actually have MS in Puerto Rico, and that's more than you would think. And then when you look a little bit more carefully, you find out, well, the genetics of those people are actually European descent. And so maybe that's what's doing it. And we don't know if it's because there's some sort of virus that's attacking people when you live further from the equator, or if there's some parasite that lives closer to the equator that's protecting people against multiple sclerosis, or if it's sunlight and vitamin D.
Thank you. Before I continue with the questions, I want everybody to know that these questions were designed by a person all the way in the back of the room. Her name is Jennifer Falk. And Jennifer, can stand up. Everybody thank Jennifer for putting these questions together. Where is she? I don't know where she went. All right, so she's not here right. Oh, there she is, showing up now. Great. So everybody watching on webcast, sorry you can't see her, but she's back there, okay? Now, let's go forward, okay? So, talking about communication, let's talk about what do you find specifically works in your practice when communicating with patients and their family members?
So I think that, we go through training and learn a lot of really big words that only we understand amongst each other, and I find that to be completely and utterly useless when talking to a human being. And so I think making sure that you can connect with them and explain something to them in a way that they absorb and understand is critical. Otherwise, it's a failure to launch. And, we talk about a therapeutic relationship. I think that's based on honesty and being upfront and straightforward.
Some things are pretty obvious that they're bad. Brain shrinkage, bad. Black holes, bad. New lesions, bad. Yeah, the things, some symptoms that people relate are really disabling: incontinence, limitations in doing things, trouble thinking clearly. So we try to keep it down to a few problems to talk about. If it's worth talking about, it's worth focusing on, and that really works well when a visit is more focused. There's certain things that you have to get through a visit as a neurologist to make sure people are safe and things are on track, and some of it's got to be driven by the physician, some of it needs to be driven by the person who's there with what's the biggest priority right now, and knowing what's been done and what you want to try and what the options are is important.
Well, to Dr. Boster's point, the word jargon is a fancy word that means fancy words. And there's no space for jargon, not coming out of our mouths, and frankly, not coming out of yours either. And I think we all get frustrated as neurologists when a person walks in and says, I have neuropathy. They're trying to help me. They're trying to say neuropathy, so pathological nerve. So I think they're trying to tell me they have pain, or they have numbness, or they have tingling, but I'm not quite sure. In the meantime, as a neurologist, I hear the word neuropathy, and I think peripheral neuropathy, and that means I think diabetes, 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 and I spend 15 minutes thinking about diabetes, and the person in the room doesn't even have diabetes. And so don't try to use fancy words to try to help us. Instead, explain in real language, in real words, what's happening with you.
I'll say, how would you explain it to your best friend? And so say tingling.
Yeah. It stings, it burns, it twists, it cramps, it's sharp. We spend a lot of time asking you to give us the details.
Awesome, thank you. On to another subject. Let's go on to understanding what a comprehensive MS healthcare team is. Can you please define or explain in the most ideal circumstances what a comprehensive MS team would look like?
So taking care of MS includes a village. And Dan talked about a key village member being your care partner. And we want to make your village as big as possible. And so in a comprehensive way, we don't just want to give you a medicine. We want to give you a medicine, and we want to give you a support group, and we want to give you a physical therapist, and we want to give you an opportunity to express yourself, and we want to give you a speech pathologist. And I can go on for 24 minutes. The point is that we have to meet the person where they need to be met, and a comprehensive care team is, in my opinion, a great way of delivering that opportunity.
It depends on what people's needs are. Some people with lower disability, they need good primary care. They need the neurologist to be there for them. Those two are kind of the minimal team beyond your family. When you start to develop problems that are beyond the expertise of that crowd, you're going to have other people involved. If you have limitations in what you can do, you're going to be directed to the appropriate rehabilitation person to give some ideas, depending on the skills in the practice, what kind of assistance you need with vision and cognition and staying at work. All those things are very specialized additions to the people who are caring for you, and the benefit of having a good core nucleus of people is they know who to bring in and when.
Surround yourself by people who love and care about you, and don't be afraid to make trades when needed. Think of yourself as the general manager. You're the general manager of the team that you're surrounding yourself with. And if somebody doesn't play their part, somebody doesn't do what they need to do or isn't trained to do what they need to do, don't be afraid to make a trade.
And that includes the neurologist. And so if you're not connecting with your neurologist, it's appropriate to seek out a second opinion. And that's an okay thing. And we have to be okay with that because it's not about us. It's about you and your goals.
Great answers. Thank you. What do you tell or what can you recommend to those that do not live near a comprehensive MS center? Those that are in truly rural America, those that are an hour plus away from the center, or those that just don't have transportation to get to an MS center. What can you say to all these people?
Once again, comprehensive care doesn't mean it all has to be in one place. And it doesn't mean that everybody has to be working for the same institution or for the same employer. The idea is to surround yourself by people that you need to be surrounded with. And so if you live in an area where there's not a big MS center, but there's a neurologist who's compassionate and caring, then you want to work with them. And you may find that there's a physical therapist that your friend told you about who's really caring and maybe wasn't trained at the highest, fanciest physical therapy school, but really is the most caring person and really wants to go and learn more about it. And so really just try to surround yourself with people who care and really can do a better job of taking care of you.
And to piggyback off something you said earlier, the interwebs have changed access. A plug for you guys, MS Fusion News, their website is a reservoir of profound thought, and the world thought leaders in MS have been recorded by you guys, and you can log on your phone and watch videos of folks sharing their subspecialty in this field. And so I do think that there's more access than ever before, and it doesn't have to be in your town, it can be on your computer. And this, I'm talking about education and upping your own game and your understanding.
A neurologist who wants to treat you and listens to you, examines you, is a good neurologist. He's going to know when something needs more expertise than he has or she has. The only person you need to be very afraid of is somebody tells you don't need treatment or come back if you have a problem, or I think you're doing fine when you're not doing fine, and can't explain it to you. That's the kind of neurologist who's not going to be attuned to your needs and what you need to be successful with managing your disease.
Thank you, and thank you for the plug. That was very nice of you. So, next thing, MS relapse. What can you tell us about how to manage MS relapse? What do you tell a patient that tells you about why they're not feeling well, or is it common? Are they having the same symptoms, so on?
Well, really, the hallmark of multiple sclerosis for a lot of people is this thing that we call a relapse. It's easier to say than it is to really realize what it is. And I think one of the common questions people have is, how do I know if I'm having what we call a relapse, a flare, attack, exacerbation, or am I having progression? And one way I think that's a little bit easier to think about it is, if you say to me, you're not walking today like you did 5 weeks ago, you may be describing an MS relapse. If you say I'm not walking today like I did 5 years ago, then what you're describing potentially is MS progression. And it's not so different what the actual symptom is or what the problem is, but it's different the time course, how fast something's happening. So we generally don't think of relapses as being very sudden, but we think of it as coming on over days to weeks to months and then slowly going away. It doesn't always go away completely. And we do things sometimes to try to make it go away faster. And that's when we think about treatments that can try to reduce the inflammation or the swelling.
If it started today, it might be an infection rather than a relapse. I usually give it 3 to 7 days to see, because of the unfortunate experience of treating people for relapses when they actually had significant infections that weren't apparent yet. But as Dan said, if you can tell when it started, it's probably a relapse. Relapses are much less dramatic and much slower onset generally in people who are on therapy than they were in people who aren't on therapy.
So I like to talk about the 24-hour rule, because if you're given a chronic diagnosis, any chronic diagnosis, diabetes, MS, and your nose itches, you'll ask a rational question. Is the nose itching related to the condition that I have? That's a normal human question. As Dan pointed out, MS relapses are subacute. It's over hours to days, typically the onset. And so if the symptom has lasted less than 24 hours, it's less likely to be an attack. It's not impossible, but it's much less likely. And I like to teach my patients about that so that they can have a peace of mind and so they don't go bonkers and so that they have a framework to know when it's a good idea to call. And at our center, if you have a new symptom, I don't expect you to diagnose it. I just expect you to bring it to our attention. And in particular, if it goes on longer than a day, I want a phone call. And then we can talk about it and bring in and sort it out.
Speaking about that phone call, I know your offices are busy, but how many of you have called a doctor's office and can't get somebody to respond? Thank you. And or what if they cannot get an appointment to see you? What do you recommend?
So at our center, we have adopted an urgent triage model where we have 2 full-time nurses that are chained. I mean, they sit near a telephone, and they're goddesses, and they triage phone calls. And so a patient calls and says, I'm numb in my foot, and they help figure out if they need to be seen right away. We've embedded slots in our schedules to allow us to try to accommodate quickly. And that's how we've tried to address it, in our own center.
Most of my patients are too complex to deal with over the telephone, and if somebody has an urgent matter, we see them urgently. And the MS relapses in general are never an emergency. If you think it's an emergency, something's really wrong, and you need to either show up in an office or in an ER. There are all kinds of symptoms, and there are some that are dangerous. Not being able to see, pee, or walk is an emergency. Otherwise, the information gained from observing the symptoms, if you can manage them, is very important to knowing how to treat them. And making sure you get it right the first time and you don't hurt somebody with a lack of information is the main reason for needing to see someone. And whether it's me or a physician in urgent care who talks to us because you're too far away, that's what's important.
Different neurologists are going to have different ways of communicating. Yeah. Some people are going to use the internet, are going to use email, or different versions of that. I think it's important to have that conversation with your neurologist. When you go and you have one of your first few visits, I think it's a good idea to talk to them about how are you going to relay information.
Great.
Come to an understanding.
Great. That was an important question to ask. All of them are important. I want to thank again Jennifer for doing this. But now we'll go on to priorities and goals, okay, in living with MS. In seeing so many individuals impacted by MS, what are your recommendations to patients in regards to setting their goals and their priorities in both their personal life and in personalizing their treatment plans while living with MS?
So one of the very first things that we talk about after we've discussed what is MS is goals. And I don't mean goals of MS care, I mean life goals. So this is a disease you'll die with, not from. And I think it's critical. Actually, I demand that my patients have a conversation with their loved ones about what they want to do. And I'm talking about, I want to stand at my grandson's graduation. I want to walk my daughter down the aisle. I want to finish my master's degree. And that's a follow-up conversation we have when I see them next. And the reason I say that is because we want to keep you, and we want to make you the best you can be. And I need to know what those goals are. We will custom tailor your treatment to try to accomplish that as close as we can get.
I assume people don't want to know they have MS. I just sort of proceed on that basis, and we try to deal with symptoms. We try to choose a therapy that's going to control their disease completely based on the experience we've had with them.
So, sorry.
No, I think different people want to have different goals, but I think everyone's goal is they want to feel as good as possible. And so I think an important thing to do is to remind your neurologist that this isn't just about fancy words like relapses, progression, fancy machines like MRI. MS is about the day-to-day symptoms as well. And I think too often people who are neurologists and people who specialize in MS start thinking about this bigger pictures of MS and forget about the day-to-day symptoms that people want to get rid of.
Thank you. 2 more questions, and then we're going to give it to the audience. First one is, going back to the medical jargon that you spoke about earlier, what is it that you, as physicians, want the patients to bring to you so that way you could actually really understand how or what they're feeling or not feeling?
I want a person to write down before the office visit what are the 3 most important issues they're facing nowadays. I want them to talk to their loved ones and say, what have you noticed that's going on with me? That way when you come to the office visit and I say, how are you doing? You don't just say fine. Fine is nice if you're seeing someone on the sidewalk and you're having a casual conversation. It's like saying bless her heart, right? It's just a thing that we say, we're doing fine. It's not helpful when you're seeing your neurologist. When you start to say, oh, I'm feeling fine, your neurologist is already thinking about the next person in the waiting room who might not be feeling so fine. So I want a person to really write down beforehand. I want a person to come as prepared as possible to the office visit.
Great, thank you.
Any kind of quantitative information you can provide. I missed work 4 days this month because I couldn't make it to the bathroom and had to go home and change. That saves me about 10 questions to figure that out. We get a lot more done the more you can summarize things, and we know you're upset about symptoms and things. And, if you tell us, you're tired of pain all over, well, yeah, but I need to know what those pains are. So the more you've thought about it and can explain that to me, the more we're going to get done during a session to try to solve those problems for you, because it's not a simple problem to solve.
It's your disease, not my disease, but I want to help you. I want to be that village member, and I need you to be honest with me, and we only have a half an hour. So to Dan's point, when I say, how you doing? They say, fine. I said, is that a socially polite fine, or are you really doing great? And they normally say, no, I'm not doing so good. There's a couple things that we want to touch on with every visit. I think there's some things looking at mood, energy levels, quality of sleep, ability to use the bathroom, risk of fall. These are things that are really, really important to touch on. But I think the bigger issue is to have a very open and honest conversation with your clinician and share with them what's bothering you.
Thank you for those answers. Question that I'm going to throw to all of you now, all right? A patient needs to change their medication. Whose decision is it? Shared decision making. Can you tell us about this?
Well, decisions don't happen in a vacuum. It's not like 20 years ago where you go to the doctor and the doctor tells you what to do and you do it. No one listens to anybody anymore, and it's not just our lives, it's your life. And so it's a decision that's made together. And I think one of the great things about being a doctor is that in a very short amount of time, and it's becoming shorter and shorter, we have to figure out what's important to you. Are you a person that takes risks or not a person that takes risks? Are you a person that would go skydiving, or are you a person that wouldn't go? Are you someone who would go to the casino or someone who wouldn't go to the casino? Are you a person who wants to take risks with newfangled MS disease-modifying therapies, or do you want to go on older ones that might be a little bit more cumbersome but might have better safety profile? And so that's where we really have to work together as much as possible.
I think that kind of discussion is really good to have with your physician. When it comes to the first treatment for your MS, it's not as important as the second treatment. If you're not doing well, either with the control of the MS or with tolerability, those issues need to be discussed. Your other health problems actually matter a lot in our ability to choose certain therapies, and people don't realize how many different factors there are that go into the physician decision making for what might be a good treatment. It's not a simple thing, so you may get quite involved in a number of questions. And if your family care or internist never communicates with the neurologist, never sends them any notes, it's very cumbersome for us to try to figure that out from you. It's better if they do that. Now, they may not want to do that, but we may have to ask for records, and if we don't have those records at a visit of how you're doing, we're not going to be able to make decisions very well. So trying to make sure that the information flows between your physicians is important.
A group decision is exactly that. And typically the group is the folks that you bring with you and the clinicians in the room. And it's a conversation. And oftentimes I'll share my biases. I'll share my preferences and why I feel that way. And then I need to shut up and listen to how you feel about that. And I'm fond of making lists of drugs and crossing them off and seeing what's left. It's an art, and it's a moving target. And what works for an individual at one point in time might be not the right choice soon thereafter.
Great answers. Thank you, gentlemen. Let's give them a round of applause. We're done with this portion. All right, so seriously now, we're going to go around. We got Ken over here and we got Jeff over there with microphones. I need you please to raise your hands. You will not be seen by the cameras, okay? You need to change your voice, act like Mickey Mouse or Minnie Mouse, whatever you prefer, all right? Yeah, please do that. They want to be entertained up here too, all right? But show of hands. Let Ken or let Jeff see you, and then let's get this going here, because I'm sure you have questions. Somebody's got to have a question to get started, right? Center of the room.
I know you guys are very big into research. What is coming down the pipe in research?
Drugs that make people better. They're already here. You're just not allowed to hear about it from the government. But some of the drugs we have right now do make people better. There are ones that are specifically being looked at to repair disabilities that don't recover easily. There are better treatments for walking, better treatments for pain, better treatments for bladder, better treatments for strength. It's a huge investment, and so if you want companies to test these things, write letters, be in research trials, all those things.
Yeah, I think what we're seeing is some of it is Me Too, basically a new version of older medications, new and improved. Some of it is totally different mechanisms, totally different ways of treating MS, and some of it is looking at other types of MS. A lot of our focus has traditionally been on what we call relapsing forms of multiple sclerosis, and we're seeing more interest and more research going into progressive forms of MS as well.
I think some of the most exciting breakthroughs are in our understandings of MS. And we still don't understand this disease nearly adequate, but it's getting better each year or each decade. And so I think some of the biggest advances are our ability to better understand what's happening in that individual. And that's really exciting, and that touches on how we diagnose and how we treat and how we manage in our goals.
Thank you. So we're going to go to the right side of the room, but I'm still feeling so strong about how they were during the previous portion of this program. Again, I want to thank you guys. You guys did great. So now we're going to go to the right side of the room. I'm going to go back and forth, all right?
Given the success of some of the newer drugs, why would we not be starting with the heavy-hitting drugs from the beginning?
So this is a philosophy, right? And as Dan pointed out, some people take their paycheck and go to the casino. Some people have it deposited in their wife's account. And one's not right and one's not wrong, but it has to do with your goals and what you want to try to accomplish. I'm very biased, and I want to put you on the most effective drug you're comfortable with. And the most effective drug you're comfortable with might not be the most effective drug. It might not be the fourth most effective drug. We have to figure out for that human, for that individual, what's right for them. And so that's it's not one size fits all.
For the foreseeable future, treatment decisions are going to be infected a large part about how you've done with whatever drug that the insurance company thinks you should take first. And I highly encourage everybody to get treatment experience quickly with drugs that are popular and old and becoming generic, because you are going to be constrained to using those if you have not. Nobody wants to get a letter on December 1st saying, as of January 1st, we'll no longer pay for this therapy that's working well for you because you never took X. And we're going to have lots of X, Y, and Z that you had to take 5 years from now. So you might as well go ahead and try them, because if your MS is not going to be controlled with those, you need a stronger medicine. And those are already denied to you in many ways, either by the government or by insurance companies, and will continue to be so in the future. So you should not hesitate to cycle rapidly through medicines and find out what's going to control your disease.
To Dr. Boster's point, there's still an unanswered debate in the United States. Should we start out with what we think of as the most effective medications, or should we start lower but maybe potentially safer or been around for longer and build up as we go? So that's one unanswered question. And then Dr. Hunter brings up the other topic, which we hadn't really talked about too much until now, which is that there's another person in the room, right? There's the neurologist, there's the person with MS and their loved ones, and then there's the person paying. So there's the insurance company, and the insurance company is going to dictate a lot about what medications you are or aren't on.
And I want to highlight something that Sam said. He didn't say go on one of these first-line medicines and stay on it. He said try it. And if you're doing well, awesome. And if you're not, get off now.
Question over there?
Yes, my mother has Alzheimer's, just beginning, and that means I have 50% chance of getting it. How's my MS going to be affected by this?
Well, people who get Alzheimer's disease usually get it after a very long time of very minor declines. Everybody's different. Every family's different. MS adds up with every other disability you have, and Alzheimer's disease usually starts with memory problems that are pretty dramatic, and often the individual doesn't perceive them and their family does. And of course, that's going to be different than what MS memory problems are like. Your memory's slow with MS, it isn't gone. It's effort related, and so it's a very different process. It's usually distinguishable as people get older.
Right rear of the room. Right rear of the room. Is there a question there?
Yeah, I'll disguise my voice, okay? I would like you all to address the conspiracy theory that MS could be cured, but there's more money to be made in treatment, by telling us where are we in research on the path to a cure, that big C that everyone really wants. We don't want more treatments, we want a cure.
So in medicine, we cure almost nothing. I mean, we don't cure things. Like sometimes with very localized cancers, you can cut it out and it's gone. The vast majority of conditions we treat, and I'll use diabetes as an example. A couple decades ago, diabetes killed people. You lost your kidneys and you died. Now you don't know that your friend has diabetes unless you eat chocolate cake with her and she gets out her insulin pen and injects her. And so we have successfully, in many cases, controlled diabetes. And to be very frank with you, I don't think we're going to find a cure in my lifetime. I hope I'm wrong. But our understandings of MS are in some cases in their infancy. But what is possible in my lifetime, I think, is to make MS boring and to make the lives of people with MS like the lives of folks with diabetes, well controlled.
Doctor's advice is cheap. And if you want to know more about what can be done for your MS, see somebody who understands how to use medicines that can completely change the course of your MS. And there are several of these with different advantages and disadvantages. And let me tell you, there's the only thing that's close to a cure has been out there a long time, and the government won't let the company even tell you how good it is. They won't. The physicians who know about it. There are lots of good treatments, though, and treatments will often control the disease for many years and give you freedom from disability for decades.
Okay, next question, center of the room, right here.
Yes, I'm wondering how you feel about the affiliation of mono and MS and it triggering it.
So the question was about mono and multiple sclerosis. So mono or mononucleosis, the kissing disease, or the disease caused by Epstein-Barr virus. We've for a long time tried to say, well, what causes MS? Is there some sort of common virus that happens? The thing with the monovirus, with the Epstein-Barr virus or EBV, is that it's very common. So 100% of people with MS have been exposed to the monovirus, but 80% of people who don't have MS have also been exposed to it.
There's a lot of kissing going on, you see.
And so it's not clear to me. I don't think that we're going to find one virus that causes multiple sclerosis or even that sets it off. I think in different people, there's going to be different viral triggers that happen. And one of the interesting theories now that I think there is that maybe there's some DNA inside our bodies that's actually not originally human. It turns out that 8% of our DNA, millions upon millions of years ago, was actually from a virus. And it's inside our bodies. And something has to make that DNA get reactivated. And things like the monovirus, like Epstein-Barr virus, might do that. And that might set off the cascade of multiple sclerosis. So we're still learning a lot about that, but I don't think it's going to be as simple as mono causes multiple sclerosis.
On that same line of questions, on that same line of question, do you find anything that's being used in the environment that might be triggering greater or worsen your MS?
Smoking cigarettes.
Tobacco, number one.
It's the best way to make your disease worse as quick as possible is to smoke.
Even passive exposure to tobacco. Air pollution, standing in front of a campfire, all the same thing. It turns the immune system on. The immune system thinks you have TB. It goes nuts.
Okay, next question. Back center.
Yes, I had a question about immune therapy. We was talking to the doctor the other day, and he had mentioned gene therapy was an option coming up. Have y'all
So I don't know if you're talking about stem cell therapy or a different kind of therapy.
That was it, yeah.
Stem cell therapy is sexy to think about. I'm going to swap out your bone marrow and take care of the problem. It's not prime time yet, and it's not something that, in my opinion, should be done outside the context of a clinical trial. I think there may be a day in the future where it holds a place in treating this autoimmune condition. But the reason I use these words is right now there are predatory people out there that'll take your money and they'll do a stem cell transplant. And the only good thing about that is it's not real, because a stem cell transplant can be very, very dangerous. And so I think we have to have pause, and I encourage everyone listening, if you're going to consider something like a stem cell transplant, please make sure it's in the context of an appropriate clinical trial.
Most of the time when I hear people who are looking at that, they haven't enough information about the really good options for how to treat MS. There's really safe, really effective treatments, and that information is cheap. Doctors are cheap. Disability and medication not cheap, but they work.
Thank you. You?
Yeah, so the idea of stem cells is one cell becomes another cell. And all of us start out with two cells, right? We start out with one from mom and one from dad, and 9 months later we become a fully formed human being. And so the question is, could you give a person some of their own genetic material, and then they would have a new type of either immune system or new type of nervous system coming out? Too often, I think the people who are looking at stem cell research are people whom stem cell research won't actually help. They're looking for the type of stem cells that are going to make new nerves or new covering of the nerves called myelin. But most of the stem cell that's offered and most of the stem cell research is actually about rebooting the immune system. Mm-hmm. And as Dr. Hunter mentioned, we have other ways that we understand a little bit better that are actually made to reboot the immune system.
Yep.
Great. Adding anything? Nothing? Great, thank you. Question here?
It's kind of twofold. Is there a thyroid and MS connection? And if you have a thyroid condition, does it make MS more difficult to treat and vice versa?
So there are bunches of autoimmune thyroid conditions, and I'll make a general statement that if a human has one autoimmune condition, they're more likely to have a second autoimmune condition. And so we see plenty of people with MS that also have thyroid. Thyroid has a very interesting space in MS, and there's impact of thyroid from the medicines that we use to treat the disease. And so I don't know that there's a direct connection, but we bump into it a lot.
It's the most common immune disease that we see in people. About 10 to 15% of women with MS get autoimmune thyroid disease, which is usually underactive thyroids. And we see it precipitated a lot of times when people start on MS treatment. The interferons and Limtrada are the two treatments that precipitate thyroid disease. And it's clearly immune mediated. It tends, because it's more common, you tend to see it in families. But it's the same genes, we think, that predispose people.
Thank you. Any questions out here?
Concerning stem cells, is it possible if somebody were to get stem cells from somebody else who had MS, could somebody else get MS when you're dealing with stem cells like the animal model is created?
Unless it's an identical twin who's giving you stem cell transplants are very dangerous, and they're used only in extremely life-threatening conditions.
Question over here.
I had a question about like MS and pregnancy, and maybe have you noticed any changes in women that they were diagnosed before pregnancy and like maybe after having the child, and just kind of like your experience with it?
Well, oftentimes pregnancy can actually be the best time for somebody who already has a diagnosis of multiple sclerosis. And the pregnancy can kind of control the MS and push it down. But the period right after pregnancy, so when delivery happens, can actually be a more active time. What that means also is that some women don't get diagnosed with MS until they're either in that first trimester of pregnancy or more commonly when they're actually delivering. So right after delivery can be a time when the immune system and the body's defense forces can kind of get revved up, and you can have that attack of multiple sclerosis.
Great, thank you for that. It's a question all the way in the back.
I have a question about vitamin D and children and grandchildren. Pediatricians don't seem to feel a need for youngsters, infants and toddlers to have vitamin D. What are your opinions about that, if there is a parent or grandparent with MS?
So there's interesting research linking or suggesting association with low levels of vitamin D and an increased risk to develop MS, and low levels of vitamin D driving MS disease faster. And there's some thoughts that if you supplement vitamin D, that might be helpful. It might be helpful in decreasing the risk for MS, and it may be helpful in slowing the disease down. And so this is an evolving line of research that we're still learning about. I believe in it, and I tell my patients, I can't treat your children, I don't know how to do that, but I would definitely talk to their pediatrician about having their levels looked at. And if you live in sunny Columbus, Ohio, where I hail from, we don't have a sun, or at least not 7 months out of the year, and that's where we get most of our vitamin D. And a lot of people, including children, have really low levels. And so I think it's at least worthwhile to talk about checking levels and supplementing in children. But again, that's outside of the scope of me taking care of an MS patient.
There's a big difference between what a child needs to survive and what a child needs to have optimal health. And the recommendations that have been promulgated by the people who are looking at optimum intakes of vitamin D for a child, it's 1,000 units a day per 25 pounds. If you live, in Southern California and play outside every day as a child, you get plenty of vitamin D. Most children don't. There's really very little vitamin D in milk, and children are drinking less milk than ever before. If you want to get your child vitamin D, you can give them a Chewy supplement. They make them in 1,000 unit sizes. You can also have them eat fish, which is loaded with vitamin D. If you can get them to eat mushrooms, good luck. They're loaded with vitamin D too.
I think that is the way that we're moving. It used to be that if somebody had MS, there was very little we could say to them about how to affect future generations. We just usually said, well, if you have MS, it's not that likely that you're going to pass it on, although there are families where there's more MS. But I think now, we can talk to people about supplementing vitamin D during pregnancy and even potentially supplementing the children. But as Dr. Boster brings up, you still are confined by that relationship that your child has and that you have with your pediatrician. So as adult neurologists, we don't want to step on that line because, vitamin D is a hormone. It's something that you're giving into your body. It can affect kidney stones. It can affect other things. So it's a good idea to raise that issue with your pediatrician and say, I'm not just asking because I just want to give them vitamin D. I'm asking because I or my parent has an autoimmune condition, and what is the maximum amount of vitamin D that you feel comfortable with my child having?
And to piggyback off that, I think there's a couple other things that research has taught us about a child's risk to develop MS. And so it looks like low levels of vitamin D, even in utero, but in children might increase their risk. A couple other things have come out. Exposure to tobacco smoke, even secondhand smoke, can increase a child's risk. And that's something that we don't talk about enough and educate enough about. There's also some papers that suggest that morbid obesity amongst children can increase their risk. And so to Dan's point, there's more and more that we can do to try to help empower families to lower the risk of their loved ones.
The vitamin D levels are highly genetic. If there's one person in a family who has low vitamin D levels, usually everybody in the family will have a low vitamin D level. It's some kind of adaptation that came out of this Northern European set of risk genes. It keeps the immune system running fast. This immune system makes more cells than is necessary. They're turned on more aggressively. Probably helped you survive TB. We don't know exactly why it is, but it's from this Northern European set of genes.
Any questions out here? If not, I have one for them. All right, my turn. So there are a lot of young people being diagnosed with MS that also want to have children, and yet they're concerned that they may pass on their MS to their children. What can you say about this?
Less genetic than just about every other disease you run into. No.
Okay. And another question I have is, are there any biomarkers that you're using these days okay, other than MRI or MRI. I mean, can you tell us about this and how you're using a biomarker possibly to keep track of your patients?
I think the very best biomarker is something that doctors call HPI, which is the history of present illness, which is talking to a human being and asking them how they're doing. I mean that wholeheartedly. I think that we learn the very most from the interview that we have with the human being. I think we learn second most from examining them. I think third is the MRI, as we've talked about earlier. And there are some things that are emerging, but they're still being kind of sorted through, like using the OCT, this test that looks at the thickness of the back of the eye. And increasingly, we're seeing really cool correlations with thinning OCT and bad outcomes. And so a lot of those things are still in the works.
There's old ones like electrophysiology. The MRI is one. There's one that's coming called neurofilament light chain that Dr. Boster talked about. We may literally take the temperature of your brain with a blood test in a few years. It really looks promising for giving us a window on just how well controlled the MS is on a microscopic level that would supplant trying to do that with MRI. But there's a blood test that's been approved that's out there for telling people whether they look like they have MS or not. Well, you know, I've had a hard time figuring out how to use this. I think it's wonderful, but in a different era, it would have been more helpful. But now it's like, well, if you don't have MS, you have something else. If they don't have anything else, they clearly have MS. You know, regardless of what any test says.
Yeah, and you know, Dr. Hunter, you're right here in Franklin, Tennessee. You know, how do you use the OCT or the optical coherence tomography? It's like a laser ultrasound of the eye. It's kind of Star Trek-like.
It is a tool for looking at the visual pathway. Sometimes we find very important things about the MS from it. You can see degeneration of nerve cells in the retina, and and what's in the back of your eye goes back to your brain. So it tells us about that pathway. People with bad MS usually have bad OCTs. But early on, he gives us the clue that, hey, there's a really significant visual problem, and it's a very useful test over years. It's very quantitative numbers, and it helps the neurology assessment a lot for visual things, and we've been doing it in our practice for about a dozen years, and it's just a wonderful test for being able to answer a lot of questions, the least of which is when somebody comes in with a major vision problem, is this something I need an eye doctor for? Is this something I'm going to treat?
Thank you. So we have time for 2 more questions, okay, and that's it. My feet are on fire standing here for over an hour, right? So we have a question in the front, one all the way in the back, and then I got something special to say, okay?
On the average time when you go see your neurologist, how much time can your neurologist spend with you? Is there a certain time that you guys can stay with your patient? Is it 5 minutes, 10 minutes? Because really, a lot of times you don't have enough time to explain what is going on with yourself.
So even before we answer, I want to highlight something Dan said. Coming prepared for your visit is a requirement for a successful visit. When we get ready to see you, we read through the chart and we look at the MRIs and we review the labs. We do homework to get ready to see you. And I ask you to do the same thing getting ready to see us so that we can be effective, because we don't have all the time in the world. And so I just wanted to stress what he said, because that is the recipe for a really successful visit.
So Great Britain, 3 minutes. You get 3 minutes. If you're really sick, you get a double visit. You get 6 minutes. Germany, you get 7 minutes.
Woo.
Italy, you get 5 minutes. Canada, you get 5 minutes. Most MS neurologists, it's between 30 and 45 minutes for a patient who's complicated, for a return visit, not a new visit. Often they're longer, like an hour.
So what do you do for follow-ups?
Personally, as long as the person needs. But that's because those of us who work in different kinds of practices are able to do that, right? So that's also an important aspect. If you're seeing a neurologist who works for a large institution, they may have more institutional rules that may allow them to do something or not to do something. And somebody who works in private practice or in solo practice may have nobody telling them what they have to do. And so if you're not getting the kind of time that you need from your doctor, that's a time when you want to be thinking about trading your doctor in.
Yeah. The problem is partially with getting the time you need is the insurance system was set up a long time ago, and it was fixed to pay doctors less every minute additionally they spend with you. And so by the time you get to 40 minutes, you get paid nothing more for any time beyond that until you get to 75 minutes. So somebody has to be deathly ill, and it's a very bad system. You would love to get paid by the minute, the same regardless, so that you could spend as much time as you needed with somebody, but that was a decision made long ago by insurance. So it's far better to come back regularly for additional appointments. You'll get more attention from the neurologist. He'll be able to solve more problems in shorter periods of time.
To add to what Dr. Kantor and, well, all of them were saying, all right? So MS Views the News has an educational tool from our website that you could actually print online and fill out online to be totally prepared for your appointment. You could print it out. You could fill it out, like I said, online. You could start filling it out like 2 weeks before your appointment to make sure that you have everything on there. I mean, it's a tool, it's a document that we use that whatever you can possibly have wrong with yourself about MS is found on this two-sided sheet of paper, all right? And so if you can use this and start completing it before your appointment, when you do go for your appointment, you'll be totally ready for them. You hand it to them. You don't even have to say a word. They all have it in front of them now of what they need to speak with you about. And then you will leave without that door sliding closed and you saying, oh, I forgot to ask you. All right? So it is something that will benefit them, will benefit you, and will benefit everybody that has these questions. We have one more question all the way in the back of the room.
With all the information given, and a lot of people in the room are forgetful, cognitive problems, can this be seen somewhere else, or how can we review or hear this again?
Is that from me?
Yeah.
Oh, that's what I thought. So we are live webcasting this right now, and on top of live webcasting... On top of live webcasting, we video record like 90% of the programs that we do. So you could go to our website, or you could just go to youtube.com/MS Views the News. Shouldn't say backslash. /MS Views the News, okay? Or you could go to our website and just click on the YouTube banner that's on there, and you visit our YouTube channel. This will be published within a couple of weeks, so that whatever you cannot remember, for like Jeff says, if you can't remember, did I just say that? Yeah, okay. So I can't remember either. I couldn't even remember what I just said, all right? But you can go to that channel and you can watch this, and you could fast forward or rewind and take your dogs out, take care of the kids, come back to it. Share it with your family and friends, okay? Very important. Share it with your doctors if you don't think that that doctor is treating you well enough. Let them listen to what these guys have to say, because not every doctor does know everything. And by the way, also, there's something that we need you to do before you leave the room, and I'm not asking you to leave yet, because we still have one more speaker, all right? And that is that there's a seminar evaluation form that everybody's been given, and we would appreciate if you fill that out, or otherwise we don't know what you liked about this program or did not like about this program. So let's start off first with saying, I want to say thank you to those that provided us the support to do today's program. We got Sanofi-Genzyme, Celgene, and Novartis, and I hope that you could all thank them for helping us do this program tonight. And secondly, all these speakers that we've had here tonight, and we've got this great cast here, like I said, my A-team. I want to thank Dr. Boster, Dr. Hunter, Dr. Kantor, Dr. Kantor, Dr. Hunter, Dr. Boster, because I can't single out who's first, okay? So should I do it a third way? No, it's okay. So 3 to the 10th power, whatever it might be. Thank you all for being here. I want to thank everybody that helped run this program tonight.